The use of Reflax on patients with acute pain. Why is this something that anybody would want to study? Well, I have patients who are not well, even when they're not necessarily injured. They live in this upregulated state of stress and depression and anxiety, and the research shows us that those levels of just upregulation, constant upregulation, can cause people to feel pain worse than it actually is. And I don't know about you guys, but I have patients who come in all the time and they say things like, I don't know how it happened or when it happened, but I just have this pain, and they go on to describe this pain, and sometimes it's traveling pain, or sometimes it's very specific to a region, but they can't remember what happened, and it's just kind of this insidious onset, nebulous, kind of difficult to figure out issue. I have always believed that there was an emotional component to every injury or condition that somebody's experiencing, and so I'm wondering if maybe Reflax isn't the missing piece of this for patients who are just kind of difficult. If they're already in an upregulated state neurologically, their autonomic nervous system is already, freaked out, amygdala moment, right? If it's already really having trouble and then something else happens, it seems reasonable that those two events, an injury or this pain, plus all of this upregulation, might kind of be the perfect storm. And so it might be a reason why I have patients who feel better after some treatments, but they just don't ever get 100% better. So I'm wondering if maybe using Reflax on those patients to downregulate the autonomic nervous system would be helpful. So the research plan is to use Reflax on patients who are complaining of acute pain of insidious onset. But in order to quantify their well-being status, I have two different scales I'd like to use. The first is the DPAS. You're familiar with that one. And so the last 4 questions of the DPAS are specifically well-being questions. What I'd like to do is look at that portion of the DPAS, go ahead and subtract the 1 point per question, as is the standard for the test, and then see about people who have a +4 on that section, including them, or maybe looking at the DASS, which is the Depression, Anxiety, and Stress Scale, and seeing if people with a statistically significant score on one of those 3 components, maybe including them in the study. So depression for that is +10, anxiety is +8, and stress is +15. So if they scored in that level of those categories, then we would include them in the study as well. We would use Reflax on those patients, and then after the Reflax treatment, we would re-administer the battery of tests that were given before and look for some sort of change. So what we want to know that pain, stress, anxiety, overall well-being scores were affected by one Reflax treatment before any other treatment was given. So I'm just curious to see if downregulation of the autonomic nervous system before we do anything else is helpful or beneficial for these patients. Okay, so now that we've talked about the hows and whys of research, let's talk about some of the studies that are out there that kind of back this up. In order to talk about this appropriately, there's not a lot of research on Reflax that's published. There's a lot of anecdotal evidence, but in order to kind of build the framework that we need to talk about a few different pieces of research and see if we can use some if-then statements to get us to where we want to be. So first of all, what is pain? Well, Sarno said that pain was subconscious rage. And then he kind of went on and said that he did a bunch of MRIs on low back pain patients and found that a lot of times where they had pain didn't necessarily correspond to the problems that he saw on the MRI. And so then he decided that for some pain there's no physiological cause, but maybe it was tied to a past memory. And therefore he deduced that this pain memory was encoded and that the best way to help people understand it would be to kind of talk them through maybe why they had the pain and the nature of the pain, and help them process that way. Ney and Featherstrawhouse said that pain, both acute and chronic, was a combination of things. And we saw that a little bit in the pain neuromatrix, and we'll kind of tie all that in too. But he said that it was a combination of emotional, physiological, and cognitive pain, and that they all three cause suffering. No matter which one is the most important, or the driver of the pain, maybe is a good way to say that they all three caused suffering. Melzack, in his pain neuromatrix theory, said that the brain was made up of a widespread network of neurons, and those neurons process information and produce this whole body sense of self. So he said that pain was a multidimensional experience, kind of like Ney and Featherstone. So we've kind of established that pain has a lot of different components to it. So if we want to look at pain, now we also have to look at well-being. Wang and Tsai, I think is how you say that, in 2001 said that there was no concrete definition for well-being. So it's something that's been very well researched, but nobody's actually narrowed it down to what it was. Diner, Sue, Lucas, and Smith said that it's a bunch of different emotions, and that they all factor into kind of this umbrella term of well-being. So joy, elation, contentment, happiness, but also stress, anxiety, depression, and then whether or not the person is happy in the current situation that they're in. And they also decided, Diner and the rest, decided that it was influenced, subjective well-being, or how a person feels about how well they are overall, was influenced by a lot of different social factors. Family, work, health, and also finances played a really big role. So if we look at pain, and then we look at subjective well-being, then another component that we need to look at is stress. It's a major component of well-being. And Grant, Gully, and Sin in 2013 did a great article, and they essentially, when you boil it all down, what we got to was when a person is experiencing stress, they report lower well-being, and that stress, their stress terminology also included anxiety and depression. And then Chapman, Tucker, and Song define anything that elicits a stress response. So anything that causes you to kind of react in a manner that upregulates your system, they considered that stress, which I guess makes sense. So stress in the sympathetic nervous system. Sletherin and Birkeland said that fear, an immediate threat of harm to the body, decreases pain perception if it's like an acute situation. But if that is a continued response for a long period of time, then that person will actually feel an increased pain perception. And then daily struggles, personal conflict, and social pressure intensify the effects. So those are two people that are essentially saying that when a person is consistently upregulated due to stress, their perception of pain goes up. So what might be a 1 or a 2 to somebody else feels like a 4, 5, 6, something magnified to them. Feeling stressed in your life can produce increase in the activity of your sympathetic nervous system. We've kind of already talked about that. And that kind of all drives that term of upregulation. You've heard it. We used it a lot this summer. And so that's just kind of the framework for that. Just stress and constantly dumping all those neurochemicals into the body, and then the body just kind of continues to upregulate. So Dr. Scare works with the Reflax people, Musgrave and Quinlisk. And he talks a lot about fight, flight, or freeze, which is essentially how the body processes and then gets rid of or moves past a threatening situation. So he says it's driven by the amygdala, which shuts off after the process is completed. When the amygdala is off, the autonomic nervous system gets a chance to rest. But when it's on, the autonomic nervous system just continues to produce this fight or flight situation. And that stress is stored in the body as procedural memory. So if I don't get to complete the process, then every time this happens, I feel this way. A procedural memory tells the body how to respond every time a similar situation arises. Looking at the polyvagal theory, which is kind of another piece of this, the polyvagal theory says that the vagus nerve has multiple jobs to do. It's responsible for the primitive vagus, so one of the subparts that they've identified is this primitive vagus, and it talks about digestion, response to threats, and immobilization behaviors. Then there's the vagal brake, which inhibits the sympathetic nervous system, and it slows down the heart. And then there's the social engagement system, which fosters engagement and disengagement. So the vagal nerve, the vagus nerve, is involved in kind of all three pieces of that. But when one part is functioning, the other parts are more difficult to access. So a patient's connection with their healthcare provider can help because of the social component if they're in an upregulated state, because it kind of blocks off the other two parts of the vagus nerve and makes it a little less easy to access. Again, that's all information from Dr. Sayer. So one of the key terms when they talk about reflax is trauma and releasing trauma. And so in order to tie Dr. Scare's theories into what trauma is actually defined as is in the DSM-4, he looked at it this way. He said that the DSM-4 defines trauma as abnormal arousal, abnormal avoidance, and abnormal re-experiencing of a memory or a situation. Dr. Scare says that the abnormal arousal is the fight or flight phase. Then he says the abnormal avoidance phase is the freeze phase, and the abnormal re-experiencing is where the procedural memory is stored. So now we get to reflax. Reflax is defined as an intense, repetitive, focused, proprioceptive, tactile input. That's a lot, right? Sufficient to induce a trance state, which with extinction of procedural memory patterns. So they get into this trance state, and their body is allowed to process the fight and flight, but it also gets to experience the freeze part of the fight, flight, or freeze. And that allows the procedural memory to be reprogrammed, I guess is the easiest way to think about it. It excites the autonomic nervous system, but it bypasses the amygdala because of the way that it excites it. It's not a threat. They don't feel threatened, and so the amygdala, remember when the amygdala is off, the autonomic nervous system is downregulated. This allows the brain to refile the shards of unresolved trauma. So they experience a fight or a flight, but they don't get to experience the freeze component, and that cycle doesn't get to resolve itself. And so essentially what this allows the brain to do is take those procedural memories, bring them together, file them in the appropriate manner so that they get to resolve. And then the autonomic nervous system then kind of gets an opportunity to relax itself a little bit. So we've picked a lot of different pieces of research, and hopefully now we can kind of put them together. Low well-being, sometimes caused by stress, can cause people to feel acute pain more intensely. It causes them to feel all pain more intensely, but we want to focus specifically on acute pain. And then feeling pain can cause a person to feel stressed. So then that kind of creates a cycle all of its own. And that cycle causes the body to be in this constant state of upregulation. Reflax could potentially be the key then to this, because it allows the body to downregulate through tactile input and components of the polyvagal theory. Therefore, to me, it seems reasonable that using reflax on a patient in acute pain who has a statistically significant subjective well-being score should prove to be an effective pain-reducing therapy. I've included my references here, and they're really small, but I've included them here just in case you want to take a look at them. Really appreciate your time and attention. Thank you so much. I'm looking forward to your questions.